We got a message that has been recorded by the Minister of the Health Minister, Olivier Véran, who wasn't able to be with us today. So I'm going to ask for it to be broadcast, and then we will continue with a session on long-acting Buprenorphine when innovation sparks debate. And I'll let my colleagues chair.
Monsieur le Président, très cher Amine Benyamina,
Mr. Chairman, dear Amin Benyamina, dear all, I would like to thank you for your invitation. In the past, I've sometimes been able to accompany you, but you will understand why in the present health situation I wasn't able to come. For the past 15 years, the ALBATROS has been the must in the congresses on clinical, therapeutic, and social elements on addictology. It's interesting both in terms of the topic and the quality and diversity of presentations. You say addiction is a challenge for other medical disciplines, and I agree with you. I believe addiction challenges the whole health system and, in general, society. For a long time, social standards have ruled the relationship with psychotropic substances and the vision. First of all, with repression, with the example of the drug war launched by Richard Nixon in the 60s, then the AIDS problem in the 80s. The vital emergency was not so much at the time to fight against drug use, but the risks, to reduce the risks people were exposed to, and then more recently, reduction of risk. The prohibition was for aiming at punishment, and now the medical care and the trial to protect drug users against the indirect effects.
Et d'avoir suspendu le jugement moral et médical.
It's now important that the moral and medical judgment has been suspended, and now we consider that the user is able to make rational choices.
Capitaliser autant que possible.
Working along those lines means capitalizing on the responsibility of individuals. In this vision, we're all potential users faced with a long continuation of practices, and let me remind you that the exposure to illicit drugs is also risky. Above and beyond this, the main discussion on drugs nowadays is based on the chronic difficulties to get scientific data and translate them into public policies for public security and not forgetting public opinion. We do have to find a path for progress in order to implement an ambitious health policy taking into account all these constraints. This dynamic balance is what I'm looking for with my colleagues from the government for the use of alcohol, drugs, and also CBD, for which the thousands patient has been included in the national trial. I would like to thank you, dear Amin Benyamina, President of the Congress, for your commitment above and beyond your precious mobilization, for example, on chemsex and the excessive use of screens and other elements. I'm sure that you will be able to lead the reflection. I'm counting on you, and I wish you a fruitful Congress. Thank you very much.
Welcome. Welcome to everyone here to this nice presentation. I think that the presentation of this afternoon will be very, very nice and very, very interesting because it's a new change in the treatment for opioid addiction. This is the first time for a long, long time that we have new opportunities for the treatment of our patients. And I think that it's very interesting to know this advantage. The psychiatry world knows very well the long-lasting or the POTS medications, but they are very different when we apply this kind of treatment for our patients. Because I think, and advance that we have important persons here that will say the reality, that it's a new opportunity for many of our patients to have long-lasting medications. Then this is my pleasure to present my colleagues. Benjamin Rolland, he's working in Lyon, and he has a very good experience in that, in opioid addiction and in this treatment, and I think it will be very good for us to know the experience. Also, there is Fadi Meroueh from Montpellier. She's working in prison, and he has very good experience in the treatment of opioid dependence or opioid use disorder, and he's a friend of me for long. We meet for long in many symposiums and congress when the situation was not so easy. And Albert Caporossi, that is a passing expert that will explain the point of view of the patient. And I think this is really this is the future in the treatment of addictions, in the treatment of mental health also, in the treatment probably of many diseases. And I think it will be very interesting to know his experience and his thinkings. Okay, let's go. Benjamin, let's go.
Merci Marta, bonjour à tous. Je suis ravi.
Thank you, Marta, and good afternoon, everyone. I'm happy to be here for ALBATROS in the midst of a new wave of COVID. So I would like to thank Amin Benyamina for always managing to organize something despite the difficult situation of the past 2 years. I haven't yet got a practical experience in long-acting drugs because we have Buvidal, which we're using in Lyon, but it takes a long time to get the approval, and there's the issue of the pharmaceutical price. Maybe you'll mention it in your questions. I hope the price issue will be solved in 2022 with special budgets. I heard today that England had earmarked quite a lot of money for long-acting medications. So we have to remain cautious about these treatments. But as Marta said, it's been years since we had such a great evolution. So let's see if we can have hope or if it's too early. Nevertheless, I wanted to share with you a number of scientific data. I didn't include my disclosures, but I must say that I work with all the labs that work on opioid agonist treatments. So here you have the example of the Caporossi deposit form. As you can see, it's a solvent that is injected subcutaneously and progressively in contact with the conjunctive tissues. Buprenorphine is dissolved and enters the blood flow either with a monthly or weekly form. The deposit will dissolve in 1 month or in a week. And in Divio, it's only a monthly form. And there's another treatment which is an implant, but it's totally different, so I'm not talking about that. It's an implant that has to be put in and removed like a contraceptive implant. But for the moment, I'm just going to talk about the deposit forms. So you have the Caporossi form, the Buvidal, with weekly doses and monthly doses. Here you have the dose equivalent. They are semi-theoretical because there's been a number of clinical trials, but in practice a number of patients will need some dose adjustment, and then the dose might not correspond exactly to this you might not have a complete fit between the deposit and the sublingual form. The specificity of Buvidal is that it can be directly introduced without going via the sublingual form, which is not the case of Indivior, which is sublocate.
Vous avez deux doses, une dose à 100 mg et une dose à 300
So sublocate, one 100 milligram dose and one 300 milligram dose. We don't know the equivalents. I guess we'll get them soon, but if I understand right,
Il y a moins de correspondance aussi exacte que
the correspondence is not as specific as for Buvidal. For the moment, we haven't got the marketing authorization for Sublocade in France.
va arriver et quand.
We have it for Buvidal. I don't know when we get Sublocade. Some countries only have one, some countries have the other, and some countries have the two, like Australia.
Pharmacokinetics.
So the pharmacokinetics, as you can see here, if you're a psychiatrist, you know that with a delayed treatment, as you know, it's the slow diffusion of the product that is enabled by the deposit form. You have a coverage which is above the efficient dose, treatment dose in the blood flow. So when you go the sublingual buprenorphine, or if you give the deposit form with the Buvidal, you have the equivalent over a week and a month. The interesting with the data of Sublocade, as always with a delayed treatment, you have a phenomenon of accumulation. So it's not surprising that you need a few weeks or months to reach a plateau covering a minimum blood value so that the patient will not have any craving feeling and not have the effect of substitution treatment. The interesting thing on in these curves is that as for all delayed treatment, the product takes time to eliminate, and this is the philosophy of the substitution treatments. Sometimes you have half-lives that are long, like for methadone or Buvidal, and they therefore prevent too many weaning symptoms for the patient. Now, some data about efficacy.
Des schémas toujours très simples, mais je vais essayer de les rendre.
It's not always easy, but I'm going to try and make it understandable for you. Here you have the flow chart for the Princeps study, phase 3 of Caporossi. 600 patients were assessed for eligibility. These were international trials. A great number of them were excluded for comorbidities. As you can see, 428 were randomized, a little over 200 per group, in a double-blind, double-dummy scheme, meaning that patients all took either active sublingual buprenorphine plus placebo deposit form or the reverse. So they all had two forms. I would like to attract your attention on the fact that it's very heavy for a patient to follow a clinical trial where they have two treatments. So we had some lost to follow-ups, not that many, but enrolling some patients and asking them to maintain for weeks or months this principle of a dual treatment is really a feat per se. Here you have the evolution of what we call retention, i.e. the number of patients who, as the trial went, were lost to follow-up. As you can see, over the 24 weeks, you have a rate of lost to follow-up, which is, or attrition rate, which is hardly over 40%, which for those of you who work in clinical departments is the same as the loss to follow-up for care cohorts.
Et le premier résultat intéressant de ce diagramme, c'est
the first interesting result on this diagram is there's no difference in retention for the deposit form and sublingual form. So we'll get better results for the deposit form, but we could have thought that the deposit form might lead patients to be more compliant, but for this trial and the retention rate, it's not obvious. Now, if you look at efficacy now,
de Camurus, c'était une étude.
the Camurus study was a non-inferiority trial. The idea was to show that the deposit form was not inferior in terms of recurrence of consumption of opioids, was not inferior to the sublingual form. So it was rather cautious now. After that, you can have secondary analysis that look at the differences in terms of efficacy. And this is the case for this trial. There were a number of analyses carried out afterwards.
Vous voyez, ce diagramme-là n'est pas très intéressant.
As you can see, this diagram,
Cette courbe-là est intéressante.
this curve is quite interesting. Not easy to understand right away, because
De schéma, en fait,
when you have you're used to these types of diagrams, you see weeks passing, but in this case, it's the percentage of patients
données d'urine négative
with negative urine test in the trial. Here you have the percentage of the patients who over the trial had at least 10% negative urine tests over the follow-up.
vers la droite.
So the more to the right you are, the more demanding it is. Here you have patients who had 100% negative urine test after inclusion. So the second, and these are the ones who had negative tests. And here you have the ones who had constantly positive tests. So there's quite a difference, especially for what we would call the intermediary patients, meaning not the ones that went right away back to illicit opioids and never stopped, in fact, using them. But I'm talking more about people who have a punctual or spot relapse during the follow-up, and there you have a difference between the deposit and sublingual form. There's one element that is interesting and which called my attention.
Quand on connaît la pharmacologie de la
Rationally, when you know the pharmacology of buprenorphine, you think that someone who is under a deposit buprenorphine should have problems when they go back to illicit opioids, as there's more affinity of buprenorphine. It's not true for fentanyl. So someone who was covered with a deposit of buprenorphine should have trouble going back to heroin. Here, once again, it's not the case. So the clinical data, once again, challenge our preconceived ideas at pharmacological level. So that's an indirect message. Here you have a more conventional diagram which shows you the rate of negative urine tests over the follow-up. You can see that's not very significant, but a difference yet between the sublingual in yellow and the deposit, buvidal in this case, in gray, with rates that can be sometimes 5 times higher, which is not negligible in this kind of population, as you will admit. Very quickly, this is the Indivior trial that has been published for Sublocade. It's a different trial than Camurus because it's a placebo-controlled trial. They convinced the FDA to give them the marketing authorization, but they did not convince CMA. So they're now launching another trial, a superiority trial over methadone, buprenorphine sublingual and deposits. So in this way, we'll have a comparison with methadone, which we don't have yet. The American trial is showing some interesting points, not about the deposits, but as you know, we don't have many studies, many trials comparing the substitution treatments to placebos, and they're old ones that do not correspond to what we do. So I'm presenting them to show you that we have these treatments give incredible results and efficacy versus placebo. If you look at here you have the retention rate. You can see the difference between the placebo and the active principle. And if we look at the results on efficacy, this is the rate of participants that have been abstaining at each visit. You see the difference. 20 or 30 years ago, people said that TSOs were not the right answer to patients who had an opioid dependence. I feel that this trial, even though it doesn't show the superiority over the conventional sublingual forms, does show how interesting they are versus placebo, and this is very interesting for addictologists, but also for the physicians in general and the politicians. Safety, the deposit form seems to be slightly higher than the conventional form, but it still has to be proven or shown, especially with the Indivior trial. Now, in terms of safety, are they more dangerous? Do they lead to more adverse effect? A number of trials have tried to answer that. There's a big Stage 4 trial, pharmacovigilance carried out by Caporossi in Australia and the US mainly. As you can see, overall, these treatments are well tolerated. You have the conventional impact of buprenorphine, which is normal because it contains buprenorphine, and you have a number of specific side effects due to the injection, and which are found a little bit at the injection of the placebo depot, but mainly at the injection site of the active ingredient. Here you have the serious adverse effect leading to hospitalization or death of the patient. As you can see, for all three groups, there have been no serious adverse effect. So some patients will probably stop the treatment. You can see that there's very few discontinuations. A little over 2% of patients are going to discontinue the patients because they don't tolerate it due to the specific adverse effect like pain or erythema or swelling at injection site. This is conventional. It's a galenic reaction, whatever the active ingredient, but they do not lead to serious adverse effect. And this serious adverse event, and with several hundreds of patients, there hasn't been any serious adverse event noted. So you have more or less the same with Indivior, the sublocade. You still have issue with the injection site, and as you can see here, there have been serious adverse events in all three groups. This was a trial versus placebo, so the 2 doses of sublocade and the placebo, and as you can see, there was no more serious adverse event in the placebo group and in the than in the 2 main groups of active ingredient. Now, beware. where the adverse events may be due to the treatment, but they may be due to something else, an overdose or another risk which has nothing to do with the treatment, and they didn't assess the origin of the adverse event. Some other data that are more and more important in scientific literature, the PROs, or patient-reported outcomes, i.e. the personal feeling of the patient. We have an expert patient who is going to tell us about that. This is absolutely a must in our medicine, practice of medicine in the 21st century. We have to have the feeling of the patients if we want to have a quality assessment. And this is what took place in this major trial that was published in the JAMA Open. Overall, when the confidence interval is above the bar, you can see that it's positive. As you can see, these patients, after sometimes with sublingual, were put on a depot form, and they were asked about their various PRO scores of overall satisfaction. As you can see, globally, they were satisfied of switching to the deposit form, the depot form. The efficacy, as you can see, there's a mismatch, which is not important because the improvement is clear in the subjective data, objective data, but it's more important in the subjective data, comfort as well, and then side effects and satisfaction. As you can see, the feeling of the patients seems to be quite satisfactory for this, in this trial at least. Same thing here, you have the scales measuring the same outcome. As you can see, basically, there's no change in the declaration of opioid use in these patients.
Et donc, il n'y a pas d'évolution non plus ressentie sur les critères de rémission tels qu'on leur posait au patient. Alors, ici, c'est aussi une étude là d'Indivior qui, pareil, montre des réductions sur l'héroïne.
Depot, they have results on heroin, Pravine, other opioids, and if they put it Peroster as an improvement versus the sublingual form, and there is also something about the other drugs that may be taken, showing that there is better stability, but again, we're talking about subjective data, and when I'm saying only subjective data, it's not negative, you have to simply compare with more objective data. Regarding the Indivior form, the patient reported feeling was different from the delayed action forms. Some data in France, if you'll allow me. Unfortunately, France has participated in none of the clinical trials that I just showed you. Too bad, but no one has asked the French teams to participate in the phase 4 clinical trials. I guess this will come when Buvidal will be authorized. However, there have been some trials, notably one regarding the users. The question we ask in France is, do these treatments make sense in the French model? It's not a crazy question, it's a real question. Because in the United States or in Australia, where the depot or delayed action forms were sold and put on the market more than 2 years ago, this was a very coercive model for the patients. The patients had to come daily to the center to take the buprenorphine sublingually, if not every day, several times a week. Access to TSO is very easy in France, so in theory you can go to any GP who will prescribe buprenorphine, and very often you will get a prescription for 28 days. I'm not saying it's absolutely easy, but it's possible depending on the area. So the question is, delayed action treatment, are they going to make a difference versus those people who had to come daily for the sublingual form? Or in France, can these treatments play a role, considering that the access conditions to sublingual buprenorphine, but that's also true for methadone, are easier than in other countries? We tried to provide an answer to this question before the drugs were sold with some French colleagues. And we listed people for whom it might be interesting. I'll go over this study that I participated in with a group of French authors, George Rousse, whom you know, Philippe Noumenko, and many others. And we asked patients who were being treated with methadone or buprenorphine
pour différencier les profils de ceux qui étaient intéressés.
In order to understand those who were interested or not interested by a Buvidal-type drug, and 50% of the patients declared themselves very interested and 50% declared they were not interested. It was sort of half-half cut. I'll go over the differences very quickly. Those who declared themselves interested were those who wanted to stop consuming opioids, whereas those who wanted to manage illicit opioids were not so interested. Seemed to be obvious. Those interested wanted to decrease the risk for their health and decrease the risk of weaning of opioids. And likewise, we found that saving money could be a motivation for the interested people. Reduce craving, reduce bad use, and encourage health improvement. So those who were interested were very much relying on those arguments for the depot form, and the fact that they wanted to avoid taking the drug, the TSO, every day. And I'll close with something that you will find interesting. In prison, 50-50 was the division, so we compared the prison dwellers versus the others, and the cut was not 50-50 in prison, and we looked at the people interested outside of prison versus those inside the prison, the jail residents, and to understand the motivation. Those who were living in jail were less interested by the injection part and the fact that it was easy, but they were interested by the fact that it was a stable dose. They were less interested by the craving symptoms if they did not get the buprenorphine. But this is a result that I find very interesting for the incarcerated patients. They were interested by the fact that the treatment could be very discreet. There's a black market for buprenorphine in jail. So this publication shows that Buvidal or other such-like options are an interesting option for incarcerated patients. Similar efficacy or slightly higher for the sublingual forms, not much difference. High interest for the patients, especially for the PI patients. If you're interested, please have a look at this publication, which we authored this year in the therapy review regarding prolonged action buprenorphine. Thank you.
Yes, better in English. You can speak now. The questions will be done at the end of the session for all the participants. Okay.
Oui, c'est beaucoup plus impressionnant d'ici que de là.
Much more impressive standing here.
Je me présente, je m'appelle Albert Caporossi.
My name is Albert Caporossi. I'm a patient expert.
Je vais avoir besoin de mon petit papier, j'ai un petit peu le trac.
I need my
France Patient
sheet of paper. On behalf of the French Patient Experts Association, I thank the organizers for having invited me to participate in this conference. The use of opioids is something that ruined my life for about 30 years, and I treated it for like 20 years. At the time, there was no Buvidal, so I can't really tell you exactly about what it would have done to me, but I was in contact with many patients, and they reported their fears regarding this treatment.
l'attente par rapport aux médicaments.
So waiting for the expectation for new drugs is something really important. I'll go over a few very quick comments, very personal comments. My first weaning attempt was in 1994. It was a total failure, so I'm very happy to see that the substitution options are increasing in numbers. And I find that part of the population is not being treated, the people who inject buprenorphine. So definitely their expectations have not been taken in consideration. Back to buprenorphine, I call it prolonged action buprenorphine, BAP in French. And regarding BAP, my substitution treatment was a complete agonist, and I was very attached to my consumption fashion. So when they told me about this buprenorphine with a prolonged delayed action, I thought, what was it? What is it? And then I thought about people who are dependent on opioids following a pain-relieving treatment. They say, I'm not a drug user. Well, Subutex is methadone, whatever you call it. So a more practical, more discreet treatment could make it easier to have access to treatment for those people, because stigmatization is bad, and the reports from the patients confirm what I think.
L'opiodépendance, ça reste encore quand même la maladie honteuse.
Being dependent on opioids is something that people are ashamed of and try to hide. Many people find it disturbing, and as Christian said, discreet treatment is very, very meaningful to them. And I did not necessarily feel like that at the time. And if we go over, we find that storage or taking a treatment or revealing to other people that you are on treatment is a problem. And in this case, there is a very discreet solution, and I think it's going to work. For stigmatization, we also have to work on the representation people have, but you can't always change the environment. And here we have a very quick solution to change the representation, the way people look at you and how you look upon yourself.
Okay.
Right, that's done.
Alors, le deuxième truc qui
Second subject.
Alors là, il y a deux aspects du côté patient. C'est eux qui le demandent. En fait.
The obstacles, well, patients sometimes. I mean, sometimes my addiction behavior was well beyond what I could tolerate. So I asked my doctor to supervise me so that the drug would not be hijacked. I mean, that's something that I asked the GP to help me with. However, we have heard about the opioid crisis in the United States. We know that Subutex has had a lot of success in France, and the trouble is that people have hijacked it and used it for other users. We have to make it easier to have access to painkillers, including opioids, and maybe because we are trying.
Coercition, en fait.
People are trying to keep us away from those drugs. It feels like coercion, really.
Je fais remarquer un truc, c'est que
I'd like to point out that coercion is something that already existed with oral substitution treatments.
Elle n'est pas arrivée avec la.
You know, the idea of a liquid handcuff did not arrive with buprenorphine. It was there already. And when you ask for a substitution treatment, you already have your handcuffs on anyway. You're already dependent. You're already handcuffed to the drug. Then there are practical issues, Subutex, gastric pain, the taste. It's not very practical, so prolonged action buprenorphine is useful. Robupride is already there, and people like it. There are also trips to sensitive countries because we walk around with drugs, with substances, and you're careful because you don't want the customs agent to ruin your vacation by putting you in jail. And going back to France as well, when you travel across France, also because you work season in the mountains or by the sea. But now it's easier. It's something that they will find interesting with this new option. There are other practical aspects. I'll just list them as they come. Having to think about it every day, daily intake, daily administration, I'm afraid of forgetting. I remember a time when we asked for substitution therapies, and that was a wish. Now I feel like the perception has changed. The substitution therapies are now something that is imposed on them and not something they ask for. And this option might be lighter versus a daily intake.
Alors, au niveau de... C'est bien, c'est que je m'aperçois que nos thématiques se rejoignent.
Well, I find that our subjects cross each other anyway. Stability.
La peur du manque, entre guillemets, et la crainte des à-coups, ça c'est...
Being afraid of craving or ups and downs, and when you're dependent on opioids, that's something you think about. Prolonged action, buprenorphine is reassuring. It's going to be the antidote to craving. I make an injection and I'm fine for a few weeks. But other people who are used to taking the drug every day, not having the drug available will probably make them feel stressed. Depending on people, the action, the duration of the drug's action will vary, so adjustments will be needed. Regarding patient feedback, some people declared that they are surprised when they make the injection. They feel like they are slightly overdosed. And some people love it, some people hate it.
Et puis il y a un petit flou au moment où
and there is also a bit of confusion when the efficacy dwindles out.
La personne elle est un peu, je suis en manque, je suis pas en manque.
The person feels like, am I craving, am I not? And they wait for 24 hours and they know. And regarding the plateau phase, after the high and the down, there's a plateau phase. And here the feedback is very good. I did not expect that, but apparently everybody agrees. The daily ups and downs are completely flattened out, and that makes people happier. The feedback is much better. For those who understand what it means to be dependent on opioids, what really matters here is the fear of craving, and people will accept any substitution because they fear craving periods. And at the end of the period here, you have to move to the tablet form while you wait for the next injection. So it will take some time to adjust. There will be a slightly difficult time between the patient and the doctor to find the right adjustment. It's impossible to switch back and forth between TSO and heroin. That's what you said, Benjamin. That's something that is due to the fact that buprenorphine is amplified by the duration of action. And for those people who have that particular profile, it doesn't make much difference in their consumption anyway. It's not as flexible as an oral substitution therapy. We are capable of adjusting, fractioning the treatment, taking a bit more, a bit less. Here you can't. And so some people consider it as a constraint or as a support. It depends on their behavior. Some people wish for it, some people don't want it. You can't really decrease the drug yourself. It's a medical decision, and that is not really shared with the patient. So patients don't always like that. Patients don't understand that it's actually his decision, not the doctor's. They feel like the doctor lies with the decision lies with the doctor. Adjustment, question mark. What do we do when we're going through a difficult period, when we are feeling stressed, when we have an oral medication, we take a bit more, a bit less. But what do we do now? Because it's injected. And there is also the danger of switching towards alcohol and benzodiazepines. Well, that would be true if the person were taking substances to look for a specific effect. But switching or accumulating various drugs is something that exists anyway. So it's just mentioned in the things that were reported by the patients. Regarding habits, by decreasing the number of times I take the treatment, I'm hoping to stop the therapy. So that means that people want to actually get out of the substitution therapy. That's one way of using it, because you move from daily to weekly to monthly, and then you don't have the drug with you and you forget about it. But one criticism lies in the fact that an addiction is a behavioral disorder. You take a drug and you wait for an effect, and hoping for that to be forgotten is wishful thinking. But for those people who look forward to the daily intake, buprenorphine is going to make a huge change. Here I'd like to make a comment. We know the triggers in the field of addictions. If you don't have the tablet lying under your eyes, that might undo the trigger. For some people, it's better. They start forgetting about it. They don't think about it so much because they don't see the tablet. And now I also hear some people who want to become more autonomous. And that reminds me of the recent experience that consisted in following the COVID crisis. The prescriptions were made for a longer period, and actually it meant that the patients were empowered. And the two healthcare providers said opposing things. One said, I'm afraid that the human dimension is going to be forgotten. And the other said, we will give the users more importance. So it depends on who is talking, the drug or the special educator in the community centers, which brings me to the final conclusion. I haven't signed an informed consent. I believe it's the patient's choice first, like for buprenorphine, and the rest of the range will be available if needed. Regarding real contribution, well, that we will hear from the patients. If the formulation is adapted, it should be made available. I mean, that's something I'm asking for. And once you know that people are afraid of craving, substitution therapies are a good solution for people who are afraid of craving, and long-acting buprenorphine is contributing to solving this issue. The first time I heard about it, I thought it was a huge challenge. There was a lot of stake. Not having to take it every day, moving away from what I call consumption between quote unquote. It's an obstacle for those who are opposing it, but for me, it's the main stake. It's a bit like forgetting about the molecule and understanding what it really means to be addicted. Addiction can be an intentional solution to compensate for a psychological distress. Often the patient has no other solution. There is no other mechanism available, no other alternative available. So we can wait for things to, mature. We can wait and learn. I would advocate for support, behavioral therapy, family therapy, relapse prevention, day hospital, all kinds of options. Patient empowerment in the process of change. And one of the main motivations would be the behavioral motivation, change motivation. Getting the people to accept the help offered. So long-acting buprenorphine goes in that direction, but it's not going to do the job on its own.
Now, Fadi, Meroueh, is your turn.
Merci Marta. Merci.
Thank you, Marta.
De nous avoir invités à venir parler
Thank
de
you,
notre expérience.
Benjamina, for having asked us to talk about our experience with the long-acting
La question
buprenorphine.
qui avait été posée, c'était quand l'innovation
The
thérapeutique.
question asked was when therapeutical innovation leads to, in the Sparks debate, and that's
Pour parler
the subject today. And I'd like to share with you my experience.
Alors, en introduction, là, je dirais
By way of introduction, I'd like to ask,
doit faire débat.
why does innovation
Surtout quand l'innovation
spark
n'est pas
debate,
innovatrice.
especially when the innovation is not so
La
new?
définition d'innovation.
The definition for an innovation is integrating the state-of-the-art knowledge in a product or service in order to provide a response to a need expressed by citizens or society. In medicine, simplifying the treatment, the therapy for chronic diseases always was the rule, by either decreasing the quantity, if you can move to 1 tablet a day rather than 3, to move to once a week rather than twice a week, And quality means 3 times a month rather than 4 times. And in the field of psychiatry, we give long-acting drugs now more and more. And we all expect for HIV to be able to give an injection every 2 months. So there was a time when people took 12 tablets a day in the 80s, and now we have one injection every 2 months. I mean, in terms of innovation, why should we be afraid of innovation when that's what innovation is? Especially when it guarantees a stable dose, an efficient dose, with much less adverse events. So why a debate? Because people are afraid. I can understand the patient is afraid. But the healthcare professional, the caregiver, why? Why should they be afraid? Especially when you consider that the fear is not based on ethical issues. I mean, there is market authorization, which comes after phase 1, 2, and 3 trials. So there are a number of guarantees that should extinguish the ethical issue. And BHD has been around for a long time now. It's not a new molecule that has just been launched. We simply took a molecule and made it a little different so it would be long-acting. So it's bad knowledge that really scares people, especially when we consider that patient feedback is very encouraging. Obviously, if the patient does not want to make his arm available, we can't inject the patient. You can't force somebody to take an injection. We have to make them understand. And people should agree with that before they agree to the treatment. Is it an evolution or a revolution? I will tell you at the end whether it's a revolution. It's definitely a slow evolution in France, even since 1995 when methadone was launched and BHD, and both were declared essential medications according to WHO. We're fine with that. We're not going back. We're all very happy to be able to treat our patients. And in France, we're very good at managing overdoses. Buprenorphine, which was widely prescribed in France, allowed to reduce the number of overdoses. Then we had the generic drugs of BHD, and then we had the BHD-NX, the gel, the caplet methadone formulation, the BHD-NX generic drugs, and the rapid dissolution BHD. But that's one take a day on a daily basis. Whereas elsewhere in the world, not only do they have the same drugs, but they have other drugs. They have a panel of therapies available today to manage opioid use disorders.
Alors, cette formule, il y a l'anglais du français.
So there is English and French in the slide mixed together, but there are 2 forms of buprenorphine, as Benjamin told us, which have been around for 3 years. So we have some follow-up in some countries. They are being given once a week or once a month. They are injected by a healthcare professional, and in the body they will make a depot, and that's why we call it depot buprenorphine. It will deposit itself. You already shown you this picture. There are 2 different methods. There's the fluid crystal technology. That's the basic ingredient, which will be dissolved during a week or a month. And we also have the Sublocade based on atrigel, another kind of compound that will act as a vector. It's going to form a deposit that will slowly become available during 1 month. Now, the difference is the concentration. We've heard from Benjamin that the sublingual or daily take, the difference is the ups and downs, because if a tablet acts for 24 hours, then there is a brutal trough at the end of the action period. And that is something that is likely to disappear with the injection. And the same applies to Sublocade, if you look at what happens in time. Now, I'd like to lay the emphasis on these graphs because the dose we have between 2 and 4, why is that interesting? Brain imaging studies have shown that removing signs and symptoms of weaning will require 50% of opioid receptors occupancy, which means more or less a blood concentration of 1 nanogram per milliliter. And if we really want to achieve blockage, so before we reach craving, 8 70 to 80% of the receptors should be blocked, which means a concentration in the range of 2 to 3 nanograms per milliliter. And that's exactly what we have with the injectable forms. Here we have a PET scan showing that the more buprenorphine you give to the patient, the more the receptors will fill, and the patient will be stable, will require less medication. And I've shown this in a different form. Here we have occupancy rates between 0 and 100%, up to 50%. It plays a role on craving and weaning. Up to 80%, the patient will be stable. And for craving to appear, you have to reach 70 to 80% of receptor occupancy. And these plasma levels are reached with all the formulations that we have with buprenorphine. Now, back to this regarding the different action levels when you're taking care of somebody who's stopped taking opioids. There's pain, there is weaning, craving, and obviously you have to be careful that the person doesn't reach euphoria, respiratory depression, and death. Sublingual can be efficient. It is efficient at very high doses. However, there may be fluctuations from one day to the next because you would need to take the drug exactly every day at the same time for things to be stable. So it's very important that we are compliant to avoid the fluctuations. When the long-acting buprenorphine, that doesn't happen because we always are above the craving level. And if we use the full agonist, then we have to be careful that we give the right dose so as to make sure that we don't go too far. And here we have a graph showing that the long-acting buprenorphine can remain below the green area, the concentration, which is always between 2 to 4 milligrams per milliliter.
So when a drug, opiate drug, is put on the market, for it to be called a drug, it has to meet a number of criteria: no flash effect, no injectable, no Torrens, no dysphoric effect, no overdose, but it has to be safe, very few side effects, no morphine metabolized in urine, and no misuse. These are the big no's. Methadone, this is all right, it's true. But some patients did not comply with this. You see there's some green, some orange, some red. With BHD, same thing. There's a lot of green, so it means that these drugs do comply with the regulation. If you see there's a blue, orange, and red, with Subusan, there's less red. It's mainly green and orange, and with long-acting, it's all green. It means that you want to stick with this criteria to be on the safe side. Thank you, Lorenzo, for giving me this slide with Heino Schaufer in Germany and a few European colleagues. What are the main challenges in terms of treatment? Those who found that the results are not good enough because it's underdosed. We know that. We have this case in France. Some doctors don't want to give more than 8 milligrams, and this is disaster. Routine, frequency or intervals in the delivery drugs, the misuse, the patients who do not participate in the decision making, and in prison, in jail. The difference between sublingual and sustained release, daily intake, and forgetting, no risk of forgetting to take the drug. Mobility, those people who have to go and outside to work or were nomadic, and those who go to a foreign country where drugs are not allowed, then of course it may be a problem. Concentration is less stable in one case, stable in the other, but no misuse, no injection, and no racket, because the health professional does the infusion or uses the needle. Patients should be comfortable with this. Continuity of treatment, someone who is released from prison, who is injected, can be okay for about a month and can be busy doing other things before she has to need to buy drugs. Now, treatment or dependency, TDO, there are limits. The limit is that many patients discontinue their treatment during the first 6 months because there's too much pressure from their family. Some patients, and my lawyer told me, if I discontinue the treatment, it doesn't mean that the addiction will treat, and maybe his penalty will be lighter. Or maybe the family tells him, once you're out of jail, you have to stop taking drugs. So there has to be some pressure from outside. There is a risk of relapse. A daily intake can be, there'll be some stigma attached on the part of co-detainees and from the family. It creates opportunity for deviation, misuse or disuse, and essentially racket. And this is the problem in prison. Sometimes patients must discontinue because there's so much pressure from the other inmates, and also because there is strict regulation. It's a daily intake. The drugs are distributed on a daily basis in prisons. I work in a prison in Madelon, Villeneuve-de-Madelon, in south of France. A few pictures. We work in a very good environment, both for us and for patients. The marketing approval for Buvidal was given in May 2021. Hospital prescription for all prison can get this drug. We organized a training session in July 2021. We explained to nurses that this is a good drug, safe to use, and we told them that the new compound, the new formulation would be available, whether they agree with this. So we did this for all patients who were opiate under OEC for opiates were aware of that the new drug was available. So far, we've had 25 patients. I have between 85 patients and 60 under substitute treatment method, and that's 12% of the prison population is on this methadone. Some come in, others are released. 22 patients were given Buzidex, 8 to 18 milligram. Monthly Buvidal. For 3 patients, we had to adjust the treatment. We increased the dose at the 28th day. There was no other overdose because we were very cautious. We want to remain on the safe side. It's difficult to know exactly how much the patient will take. So this 64 milligram was okay, but at 20 days it wasn't good enough, so we stepped up to 96 milligrams. That was easier. 3 patients were on methadone. They wanted to shift to Buvidal. One was given 2 milligrams, wanted to be win. He tried to stop the treatment, but then it resumed it. He used the weekly form instead of an injection every third day. We did it any other week. Well, it was most important. You don't want to forget taking a drug. Probably this will be positive. Not having to remember that you have to take your drug on a daily basis. And they told us being okay without taking a drug or being on drugs is okay. Is the ultimate objective. Injection on a monthly basis. Well, every month. 2 weeks. No, it's a very slow reduction. So in fact, it takes effect. It has effect under 6 weeks. They come on week 6 and 8 weeks because they feel they need it. So it's not on the 28th day that the craving syndrome will appear. It's later. Had difficult patients. I mean, people who are extremely vulnerable. and fragile. Before their release, they would go back to prisons because they were not okay. They didn't have the precision from they were difficult cases. So we injected just before the release to make them feel confident. And so they were injected, they were happy. Unfortunately, they were not released, and they're still on Buvidal. Back at day 15, we asked them how they feel at 1 month and at 2 months. Some are after 3 months. All are satisfied with the treatment. Only one discontinued Buvidal because he wants to go back to heroin. He said, "Well, I'm fed up with the heroin. I'll go back to you." So that's exactly what he did. We have more time for the staff and the nurse, so we distribute the drug on a daily basis. Suboxone, it was take 4 or 5 kilometers on a daily basis. That's how far she had to walk. Now she doesn't have to walk that much. She is much happier. Co-prescription, less sleeping drugs for people on Buvidal is because no racket, no misuse. And the next advantage is at release, it's useful in terms of risk reduction. Stabilization of dose, no risk to forget taking one's daily dose, no stigma attached, no racket, no abusive use or misuse, because providing continuity in the care or treatment is what we want to achieve most of all. So a prolonged action or long release, no need to rush to his doctor, no research, no research for product, and of course, if risk of relapse is smaller, and there won't be any risk of overdose as release of prison, because it's block the opioid. The risk of overdose in Europe, maybe not in France, but in Europe, is between 2 and 15 days. Then when the risk is higher, if there's a delayed effect, there's no risk of overdose. So the link with the treatment at release from prison is still a problem. Now we live in a paradoxical situation, because, okay, you start Buvidal in prison. I don't want to start to be on Buvidal in prison if you can't, it's not available. One released. 4 individuals left the prisons, and all of them wanted to continue with this treatment, to stay on it. 2 patients were lucky because they were transferred to another jail, and that provided this treatment. We were asked for continuity of care. Someone who gets into a prison with a potent treatment will take it to the end. Now, the paradox is that some patients are not provided with the treatment that were provided while in jail. So you should have get a benefit of continuous care or management when you release, after being released. So that's interesting from US. They put people on blockade 2 months before release, and then they follow them up. 68% continue the treatment versus 35 who were taking the sublingual buprenorphine. On the right side, 8 months is not really convincing. Fewer cases of being going back to prison if they took the long-acting form. I'll skip this. This is from England. Now, this is more costly than the Peros. So they calculated on the right side, the direct cost and indirect cost on the right, and the conclusion was that indirect costs were reduced by 17% in prison, 21% in prisons, which offset the increase in direct costs in terms of time, working time. It was a winning situation. In France, the cost on a yearly basis, treatment, misuse, diversions, and overdose when released. Clearly, on the left, 50%, if 50% are on Buvidal, Clearly, the cost will remain unchanged if you take into account all the rest, not just limit yourself to money. 5 years, there won't be any extra cost with the hospital, coming from hospital training or teaching. And this was the... so to conclude, injectable long-release injectable may limit the risk of a stigma, improve the quality of life, may reduce the gap between the need to provide treatment and what patients actually crave for or want. And this is directly related to the successful of the treatment. Let me conclude with this. There's no treatment perfect for all patients, even though the recent program in research neurobiology may lead to the development of a new pharmacology. One of the major challenges is how you administer the most efficient treatment. Thank you for your attention.
Merci beaucoup.
Thank you.
Well, we have just 5 minutes.
Il nous reste 5 minutes pour des questions parce qu'il faut absolument que la session se termine à l'heure.
I think that the presentation has been very good.
C'était une excellente présentation.
For the people who want to ask.
Je crois qu'il y a des gens qui veulent poser des questions aux auteurs de la présentation. Il faut peut-être leur faire la place, leur ouvrir les portes.
I have one question.
J'ai...
Where it is? Oh, yes. Es que no se ve nada. Yes, yes.
Oui, bonjour. Olivier Génie de Grenoble. Merci pour...
Olivier Génie, Grenoble. Thank you for this speeches. What about your experience of acute pain treatment from patients with this form of buprenorphine? It's known that it's a difficult... Well, patients on buprenorphine are asked to stop buprenorphine if they're given morphine to avoid any risk as excess doses. So what do you do in these cases?
C'est toujours la question.
Well,
à 1000 euros.
That's a difficult one.
Plus là avec une forme retard.
Especially with the long-acting buprenorphine, it depends on the type of pain. I'm not a specialist in pain, but in the most acute pain, fentanyl may be a good thing, especially post-op, because fentanyl is more affine than buprenorphine. It's a pure agonist. So specialists in pain would appreciate this, I'm sure, but we don't have any pain specialists in this room. This is exactly, we've been doing this with the 25 years. We Subutex and we treat patients in acute pain. Either we go a bit further if the pain is really subacute in a prison, we'll send the inmate to hospital so that he's given fentanyl under the control anesthesia and he will come back to prison. So this is something you have to deal with on a case-by-case basis. This is what we've been doing for the past 20 years with buprenorphine. I haven't had this case yet.
Merci beaucoup pour la présentation.
Thank you very much for these presentations. Three short questions. Once you've injected the buprenorphine, can you remove it? Second, you said that the time of action is 5 to 6 weeks and a re-injection every 4th week. So I don't understand how you can stabilize a patient with a dose every 4th or 6 weeks, and how do you calculate the doses? The doses, for instance, 8 or 12 milligrams, does it correspond to the actual dosage that he gets? So the first question was...
Enfin, il n'y a pas besoin d'enlever. En fait,
No need to remove anything.
il n'y a pas de nodule sur la peau.
There are no nodules on the skin. It's not a ball, there's not a nodule, it's kind of viscous.
Ça épouse la peau. Donc,
Nothing needs to be removed or aspirated. It wouldn't make implant. It's different from implants that you have to put in and then removed.
aujourd'hui, l'AMM, c'est...
The marketing approval is every 4th week because it starts decreasing.
Par habitude maintenant.
But patients,
certains viennent au bout de 4 semaines.
some come at 4 weeks or 6 weeks because they don't feel that it's going down.
Alors, sur les deux laboratoires, c'est un peu différent.
It depends on the lab. At Caporossi, Buvidal,
Par exemple, pour le mensuel,
on a monthly basis, 8 to 10 milligrams, so 4 milligrams monthly, between 14 and 16, 96 and 128, or even more. So that's the way we dose it. So antiver and blockade, they want to fill in the receptors, so they use 2 doses to fill the receptors. So these are 2 different concepts.
Nous, on s'adresse à des patients
So our patients know this drug.
Comme je disais tout à l'heure,
They've been on it for some time.
avec le sida ou
I don't want to compare the situation with AIDS or HIV, but they have to do it or take it every single day. At some point,
ils ont moins de fluctuations. Enfin,
there's less fluctuations. And I say that my patients smile at me when they see me, like someone who was in pain for years, and then the pain disappears.
Voilà, ce qui
So they're pleased. So, no, it's from 5 patients. Now we have 25 patients where patients come and ask for this drug at the pharmacy.
D'abord, la question que vous posez sur le fait de...
Word of mouth. So removing the deposit is probably a question which we ask only exceptionally in those patients who want to go back to heroin and want to take away the deposit by themselves. So they're bound to have lesions, yeah, but so many patients do this in other ways by injecting or they hurt themselves. Probably this will require specific education and training. That's the first thing. As to the fact that it's active for more than 4 weeks, what about the sublingual methadone? Half-life is 72 hours. And they take methadone on a daily basis, so there's no cumulative effect of doses. It doesn't because it exceeds the time taken that you'll have a cumulative and overdose effect on the country is going to be evened up, smooth. And then you have a flat curve because the body gets used to it. The way in which the product is distributed in the blood flow is such that it's going to be even, smooth out. That's why you need injection every 4 weeks.
Last question. Any other question? Yes. Last question over there.
Oui, ces formes longues sont très
The long-acting forms are quite interesting. I'm an addictologist, psychiatrist, and I work in prisons sometimes. So the new forms are very useful. The staff likes it. I don't have any experience with injectable. My question is this, as to the payment being refunded, you said that the overall cost is okay. What about a patient who has to buy his drug by himself? How is he going to react? Do you think he'll stay on the drug? Can they continue buying this? No. No patient will have to buy the treatment. The marketing approval was given by SCAPA and for prisons. So OXAPA, typically, we talk to many of them. Some say no money. Others will use some of the money to buy it. So we're in discussion with the ministry. When the treatment was started, I said, okay, I only do it if it's given outside. I started all the same, otherwise I would have waited for years and years. Now we're discussing with the ministry to see how patients who want to continue taking the drug when they are released, how can they do that? So I think that we're bound to receive an answer in 2012, and using Mixaba will be easier. Sometimes, it's frightening to start innovating. It's frightening. So it takes some time. And, it's like for any treatment. I think that we missed one presentation on the French legal situation. That's why it may not be as clear, but Fadi clearly clarified this. No patient doesn't get the treatment the doctor prescribes. Pharmacy, either in XAPA or a detention center or in a hospital, you can do this. You can have it delivered by the hospital or the jail. The patient plays no part in the delivery of the prescription. We'll see what's going to happen next with Buprenorphine in the months and in the years to come.
Okay, thank you very much. Just 5 minutes late. Then thank you very much for being here. And I think that thank you to my presenters because it has been a very interesting session. Bye.